Hello everyone and welcome to this lecture on the general principles of chemotherapy. So we are going to start the antimicrobial and today we are going to understand that what are the various general principles. Although it is part 1, so we will start. So first of all, what are the various microorganisms that are important for us to understand. First of all is the bacteria, then virus, fungi, and the parasites. So these are all the microorganisms that are of medical importance. So bacteria, we know that the bacteria is maybe a cocci such as staphylococci, then there is the bacilli or spirochetes. Viruses such as HIV virus, hepatitis B virus, Ebola virus, we all know that, then adenovirus, influenza, then rabies, bacteriophages, papilloma virus, rotavirus, herpes virus, and one more virus we all know is the coronavirus. Then there are the various diseases that are caused due to fungus such as Aspergillus species. Then there is penicillium which we use to treat the disease even. Then there is mucor, then there's candida, which is a very important cause of some important fungal diseases. Then there are various parasites such as tick or lice or fleas. Then there are roundworm, then there are whipworm, hookworm, tapeworm. All these are the parasites which are of medical importance. So before going further, we have to understand that what is the term antibiotic means. We all are knowing this term since maybe many years. You must have listened that one doctor has prescribed some antibiotic or I am going to purchase some antibiotic. So what is this antibiotic? So the antibiotic means that the substances which are produced by organisms which are known to selectively retard the growth or kill other microorganisms. So it is a substance which is produced by one microorganism and this substance retards the growth or kill the other microorganisms. So it is known as antibiotic. So it is synthesized naturally. Okay. However, in the antimicrobial, this chemotherapy unit, there are many drugs which are maybe naturally obtained. Then there are some synthetic or there are some semi-synthetic, means we have some natural agent and we added something in it. So it is known as semi-synthetic. So it is synthetic, it may be semi-synthetic or it may be a natural agent, and all these agents be synthetic or semi-synthetic or some natural, these widely known as antimicrobial agents. Okay, so the natural ones are known as antibiotics, while in combined form we may say them antimicrobial agents. Okay, so this is the very important difference between these two terms and oftenly asked in viva. But let me tell you that we usually use the term antibiotics rather than saying this cumbersome term antimicrobial agents. We use the term antibiotics, and these antibiotics can be classified on the basis of antibacterial agents or antiviral or antifungal or anti-parasitic agents. All those agents, all those microorganisms which are of medical importance and the drugs which kill these microbes, we say them antibacterial, which kills bacteria, antiviral, which reduces the growth or kill the virus, it is antiviral. Then there's antifungal or anti-parasitic agents. So now we will understand that what are the various types and goals of antimicrobial therapy. Okay, being a clinician, we know that we use the antimicrobial therapy. Okay, so we first of all we have to understand then what are the various terms which are used. Okay, it depends on when the drug is initiated, when the antibiotic is initiated with respect to the disease progression timeline. Okay, so when the antibiotic is initiated with respect to the disease progression timeline. Okay, so these therapies can be classified as the primary prophylaxis or the preemptive therapy, empirical or definitive, or suppressive secondary prophylaxis. Okay, so all these terms are very important to understand. Okay, so we will understand these terms one by one. So then this is the disease progression timeline, and we will understand this. It is a very important graph to understand all these terms. First of all, we know that we are healthy ones. Okay, so we do not have any infection, so we are not infected. Then the microbe enters in our body and we are infected now. Then we have symptoms such as fever or cough or cold, whatever they may be. Then if the pathogen is isolated, then we may know that which pathogen cause this disease. Then it is resoluted. Okay, means we are being treated, or it may be resoluted by itself, such as some viral diseases. They may get resoluted by itself, such as in case of chicken pox, it is treated by itself. Okay, but usually it is known that if you will go under some tree and you will take bath, then the resolution happens. Actually, it is resoluted by itself. So we say that that bathing under a tree helped us. Okay, so all this is the stages of disease progression. Okay, so these are the various categories of antimicrobial therapy. First, if there is no infection and you are being treated with the antibiotics, then it is known as primary prophylaxis. If you have the infection and after that you are being treated, then it is known as preemptive therapy. And if after symptoms you are being treated, it is known as empirical therapy or empiric therapy. And after pathogen is isolated, then it is known as definitive therapy. Okay, sometimes even after resolution of the disease, you are still being treated with the antibiotics. It is known as suppression or secondary prophylaxis. Okay, we will see them one by one. So first of all, let's understand the primary prophylaxis. So you all know that what is primary prophylaxis? It is the prophylaxis. It is the therapy which is given to some patient without evidence of infection. Means the patient do not have any infection. Still some antibiotics are prescribed, then it is known as primary prophylaxis. So who will get the primary prophylaxis? Of course, only those patients who are at significant risk of catching some infection. Okay, so it is like a blood proof jacket kind of. Okay, still you are not being shot uh, by some gun, but you have a blood-proof jacket, and that blood-proof jacket is known as primary prophylaxis. And one very important example of this primary prophylaxis is the administration of antibiotics in case of surgical site infection, to prevent some surgical site infection. Okay, so if you have been going through some surgery, then we all know that if you have some surgery, then you are exposed to some microbes and we know that they are going to infect you. So we give the primary prophylaxis so that infection can be stopped, it can be inhibited. Okay, so it is known as primary prophylaxis. One more very important example of primary prophylaxis is in case of some patients with HIV or AIDS. So we all know that the patients with HIV or AIDS, sometimes their CD4 cell count falls below 200 cells per mm cube. So in these patients who are still being treated for their HIV, but their CD4 count is too low, so they are immunosuppressed, so they are exposed to the opportunistic infections such as from the fungus candida. Okay, so these opportunistic infections, they can infect these HIV positive patients with low CD4 count. So we give the primary prophylaxis in these patients to avoid these opportunistic infections in advance. Okay, one more very important term is the pre-exposure prophylaxis. It is an emerging area of the primary prophylaxis. What is pre-exposure prophylaxis? It is employed in patients at increased risk of contracting HIV infection. Means if we have doubt that this person may get infected with the HIV virus, okay, human immunodeficiency virus. If this person can be infected with this virus, then we give the pre-exposure prophylaxis. It is also a type of primary prophylaxis. Okay. One more very important is the post-exposure prophylaxis. Okay, so what is post-exposure prophylaxis? It is also in case of HIV patients. Suppose you are working in some a lab, or you were working in some ward or in your some clinic in your hospital, and you are then treating some HIV positive patient and you get exposed with the needle which was used in this HIV infected patient. So still you are not infected, but you are exposed to the virus, to the HIV virus. So in that case, because you are exposed, it is known as post-exposure prophylaxis. So the pre-exposure, before the exposure to the virus, then post exposure, after exposure to the virus, these terms is known as pre-exposure prophylaxis, it is post-exposure prophylaxis. Both of them are type of primary prophylaxis. Okay, one more than type of the primary prophylaxis is the use of anti-influenza antiviral drugs in household context of influenza patient. Okay, so some patient have some influenza, then you use the anti-influenza antiviral drugs to the contacts in that house so that they may be avoided with the infection of this highly contagious virus. So then now we will see the preemptive therapy. So then what is preemptive therapy? It is when you are infected but you do not have any symptoms, then we give what? Preemptive therapy. It is like a substitute for the primary prophylaxis. So, okay. So you were not giving the primary prophylaxis and you get infected, but you still do not have any symptoms, then you are given the preemptive therapy. Okay, so it is the early targeted therapy in high risk patients in whom a laboratory or other test indicates infection. Okay, so of course we will have to know that you are infected. So if some test is used and it tells that you have some some infections. Suppose you have some PCR for some virus, then we know that you are infected with the virus. It is showing in your blood. Then we will use the preemptive therapy. Okay. So it is better sometimes to use the preemptive therapy, uh, particularly if we know that if symptoms arise, then we will treat you. Then it will be some long-term therapy with some toxic drugs. So we use early preemptive therapy in that case. Next is the empiric therapy, which is the most common use of antibiotics in the clinical medicine. Okay, so we all know we are infected, we have some symptoms, then we reach to the doctor, we say that we have some fever or we have this or some we have that. So the doctor prescribes the antibiotic. Still we do not know that what is the exact cause of infection, but we still think that it may be caused due to this bacteria or this virus. We know that it is going on in this time period, so we give some empirical therapy. So it is the most common kind of treatment. However, we still do not know the exact cause of infection. Okay. So then, why not wait for finding the exact positive microorganism? Why are we prescribing the antibiotics even if we do not know the exact cause of infection, exact positive microorganisms? What is the rationale behind that? So the exact rationale is that if we will try to find out the microorganism by the microbiological studies, then we will have to wait for the results, and these results usually take 24 to 48 hours. And if we will wait for the results to prescribe the antibiotics, then it may harm the patient. Okay, in that delay in the treatment, the patient may get highly infected. Okay, the symptoms may increase. So that is the exact rationale that we do not wait to find out the exact causative microorganism, and we just prescribe the antibiotics. We give the empirical therapy to the patient. There are other reasons too, such as the high cost or invasiveness of these biological sampling, or we know that we usually give 3 days or 5 days antibiotic therapy and the patient will be fine, so we just prescribe the empirical therapy. Or one more reason is the high predictability of the causative pathogen. We know that the patient is maybe suffering from some rotavirus. That child is suffering from rotavirus most probably, and it is causing the diarrhea. So we just prescribe the empirical therapy. Okay. However, the monitoring for symptomatic response is important. If the patient is not improving, then we will move ahead with the microbiological testing so that we may know the exact cause of this disease, these symptoms, and we may provide exact therapy. And that exact therapy is known as definitive therapy. Okay, so it is known as definitive therapy. Now we know the exact pathogen and we then prescribe the antibiotic exactly which will kill or retard the growth of that microorganism, and that treatment is known as definitive therapy. Okay, suppose you started empirical therapy and you then moved ahead with the micro biological testing, and now you know the exact pathogen, but you may or may not require to adjust the empirical regimen. Okay, if you may require, then you may change the antibiotic or you may add on some antibiotic. If you know that that your empirical therapy is fine, it it is sufficient to remove this infection, then you will continue with your empirical regimen. So the antibiotic you use for the empirical therapy are usually broad spectrum antibiotics, means that the spectrum of these antibiotics you prescribe is too broad that it will cover many bacteria. You may know that that the patient is maybe suffering from this bacteria or some this bacteria, so you prescribe a broad spectrum antibiotic which will kill 10 or 20 kinds of bacteria. Okay, and you know that in those 10 or 20 kind of bacteria, you know that the patient may be infected from one or two bacteria, so you prescribe some broad spectrum antibiotic. However, after the culture report or some sensitivity report, you know that the exact pathogen is this, and for that exact pathogen, this this narrow spectrum antibiotic will work. So you then switch on from that broad spectrum antibiotic to the narrow spectrum antibiotic. Okay. So then now in last, it is post-treatment suppressive therapy and secondary prophylaxis. So you have given the treatment, the infection is controlled, but still you think that the patient requires secondary prophylaxis. Suppose you have treated some infection in some HIV infected patient, but still the CD4 count is too low, and you think that infection is not completely eradicated, although infection is controlled. In those situations, you will continue to prescribe antimicrobial treatment till how long? Till the CD4 count is elevated. Okay, till the CD4 count is above 200, you will wait and you will continue to prescribe the secondary prophylaxis. Okay, that's all for today. I hope you understood it all. Do subscribe, like, and share. Thanks a lot. These are the references.